The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome to all you TMD warriors out there. I am Tony Urbanek, and this is TMD Demystified for our next episode. Today's topic I've entitled Confronting Dentistry's Paradigm Shift and TMD, or we can title it Confronting Dentistry's New Paradigm and TMD. I think the emphasis that I'd like to talk about is dentistry's new paradigm and, of course, how it relates to TMD. I've touched on this in earlier episodes in several ways with several titles. But I think the concept I want to get across today, and to some of you, it may somewhat be distasteful, but there are huge changes in coming down the line in dentistry and how it's delivered, who it's delivered by, how it's trained, our training programs. It's become obvious to me because part of my success in life is always confronting what is and seeing what the changes are and confronting them directly, whether I like them or not. Some of the changes are okay with me. Some of the changes are very positive. Some of the changes kind of a little scary because nobody likes change. I mean, everyone individually, or if you're in a group or you're in a business, you want to maintain status quo. Nothing wrong with status quo until something better comes along, at which point you have to put aside status quo. If that was not the fact, we would all be doing push carts or carts pulled by oxen with wheels rather than electric vehicles and Teslas. Obviously. I don't mean to be cute, but it's just the truth. And my chosen profession to begin with was dentistry. I love dentistry. I love all aspects of dentistry, although I never practiced general dentistry. I did a springboard into oral and maxillofacial surgery and other degrees and knowledge. But basically, my basic knowledge is dentistry, and my professional years and all my years in oral and maxillofacial surgery has circled around dentistry, although we bump into medicine periodically and now recently more and more. But the concept that I want to get across today, and that as it applies to you, the listener, and to TMD specifically, and to what myself and our company has to offer regarding the changes in the concepts of dentistry and delivery and what is dentistry and how it's defined, I want to get into a little bit. Again, there are big changes coming down the line. And this particular episode was stimulated by an editorial that I read in this month's JADA. Now, I don't read a whole lot in JADA, but I always look at the articles, what the major articles are, and if there's a title that interests me, especially it has to do with relationship of TMD problems, I'll always take it aside and read it. But this month, and I'd recommend every one of you, and I assume most of you get this journal of the American Dental Association. It's entitled, it's a guest editorial by Bruce Donoff, which I'll mention here in a minute. I'll talk about Bruce. To achieve oral health in America, dental education needs to evolve. And he used the word evolve rather than just change, because an evolution is, let's just say, a broad-based change, broad-based change. I've had a previous episode where I talked about the need to change our educational perspective on things that didn't emphasize so much the mechanics of fixing teeth. And we're going to talk about that hopefully a little bit deeper in a moment. But first of all, Bruce Donoff, I am aware of personally because back in the mid-70s, Dr. Donoff, who has multiple titles and comes from Boston and has been a researcher and an academician since I was a young surgeon. He was my advisor as I went through my 2-year fellowship with the NIH, NIDCR in my chosen research topic, which was the creation of animal models with craniofacial defects, animal models of craniofacial defects using the laser with intrauterine surgery to create these defects. So, and back in the mid-70s, I was able to use the first laser available in Tennessee, very first laser available in Tennessee, which was on loan from the Air Force Research Center in Tullahoma, Tennessee, to me as a young researcher. And I did that topic and created animal models, reproducible animal models with reproducible craniofacial defects from laser induction within the uterus of the animal model I used was rabbits. Okay, so that was quite an achievement. And Dr. Donoff, who I've known since then, who was my advisor within the National Institute of Health for that project. So he's a very credible person in my mind, very, very credible. And I would recommend that each and every one of you pick up your JADA and read his guest editorial. I'm not in total agreement with everything that he develops in his editorial, but I definitely agree with most of it as my perception of what's happening in dentistry in front of my eyes and my comparison to how it was when I first came into dentistry and finished my dental degree in 1973. So basically what he states, and I'm going to paraphrase tremendously, please read the article, is that we as dentists need to learn to be more of a tactician and a doctor who manages the technicians who do dentistry, to shy away from, to some extent or another, being just mechanics, tooth mechanics. And you've heard that, unfortunately, and I don't mean to be abrupt or delimiting, but it's, yeah, you've heard that for years, that, you know, that we're just tooth mechanics. Well, no, we're not, for sure. You know, you go through dental school and yes, you learn how to do certain mechanical things on a tooth, but the value of you, and that's why they call you doctor, is that you're able to diagnose and understand quality from not quality, and understand pathology from no pathology, and understand the basic sciences that are associated with every part of the area that we work on, which basically is the oral and maxillofacial structures. Now, some of us are a little deeper into it as an oral and maxillofacial surgeon with extra academic training and things. I got pretty deep into this, which is, beyond what you learn in dental school. But I was able to do that because I had the basic sciences first 2 years, which I took seriously and wanted to learn about it as much as I could so that I could apply those basic sciences to the rest of my dental career. And I was very successful in doing that and using that logic in what I did. Dr. Donoff has a few statements in his editorial that that I'd like to just read for you, and then we'll talk about it a little bit more. But he states, excuse for the reading, but he states there must be further integration with medical education and with university life, and that educational models must grow and change to accommodate new generations of learners and increase accessibility of dental education. He speaks about the social aspects of expanding our footprint so that we can service more and more people. We pretty much know that half the population in the United States of America does not avail themselves of dental services of any kind until the bitter end at best. And they end up in the emergency departments, which is an abomination. And my colleagues in the emergency department complain about it all the time. They're not equipped. They know nothing about dentistry. I've talked about that a little bit in past episodes. Our whole system, in certain ways, is beginning to break down because of the affordability of it, the availability of it. There's a lot of disenchantment from the public about the cost of healthcare in general. I believe, and I've stated before, if you don't have an answer to a problem, then you're either asking the wrong person, or let's say textbook or person, or you're asking the wrong question. So the first thing we have to do is actually confront what is. And I just did an episode on obnosis, which is observing the obvious. And what's obvious here is the public is becoming less and less enchanted, or becoming disenchanted with the cost of healthcare, and the fact that the United States has the most expensive healthcare in the world. And insurance companies, none of us in the professions, whether it be the medical profession, the dental profession, are on board with what's happening in the insurance industry, because we're all getting squeezed out of existence as providers. And it appears that the public is becoming less and less happy and totally disenchanted with the insurance industry, which I think, and this is an opinion now, my opinion, and talk about Dr. Donoff's opinion a little bit more, but my opinion is I think that sooner or later we are going to get put under a national healthcare system sooner or later. How much of that spills into dentistry, I don't know. This is all very political, very, very political, but I don't want to go into the politics of it. I want to stick to dentistry and how that affects you and I and what we do, and specifically, how this affects the educational system, and how this brings into the mix the fact that the dentist needs to be trained more specifically and more broadly into the medical aspects of what he is doing as the stomatologist of the oral cavity and maxillofacial region. Stomatologist is what the Europeans like to call their dentists sometimes. And I agree, that's a good moniker to use, because that's what you are. You're the stomatologist. Fortunately, you're able to say, I'm a stomatologist rather than a proctologist. But I prefer to work on this end of the body. And as I said, our interest in developing our educational system and our young people coming through and changing our own points of view to be more interested in things like TMD as it affects the entire oral and maxillofacial region. And I've overdone that and talked so many times in other episodes, and you can look at them all you like. There's plenty of them there. But the paradigm is definitely shifting. Let's confront it. Let's confront this problem. Remember, if you have a problem and you don't know what to do about it, you're asking the wrong person or you're asking the wrong question. So first of all, there is more than a move afoot. There is the challenge of what most dentists like to talk about is corporate dentistry, but the accumulation of multiple practices under one management system. And there is no one management system. There are multiple management systems out there that are continuing to change, but are gathering increasingly large numbers of dental practices throughout the United States of America to provide services to patients under one umbrella. We all know that. Right now, because I've done the research, we'll talk about some of my recent experience. I've done the research, and right now 20% of the dental practices in the United States are under the umbrella of a DSO of one kind or another, dental service organization, and 80% of you out there still have a private practice of either one or two or maybe several doctors, but independent practices, one operation, one corporation or LLC. So it's an 80-20 mix. It is more than a prediction. It is actually a mathematical fact because of the multiple factors. There is no one factor that in roughly 5 to 10 years, somewhere in that range, that number is going to reverse. And you could say in 5 years, you could say in 7 years. I think the longest it's going to take is 10 years. But let's just take a medium. Let's just say within 7 years, it's going to be 80% of the dental practices in the United States of America are going to be under the umbrella of some kind of management system, DSO, which currently all the details of that are being worked out. The kinds of management that go into it, because of course business and business management is what it's all about. It has to do with available capital and managing people and human resources, and of course technical changes, of which are happening extremely rapidly in dentistry. The computer and 3D printing and scanning, which is literally just months away from being standard of care, if it already isn't. Again, I don't get that deep into it, but these are huge paradigm shift changes that are already here in dentistry. And what I see is the rapidity is increasing logarithmically, not arithmetically. So all of that then filters back to how do we train our young dentists, and what do we train them in? So let's make a comparison that comes to mind is, doctors of medicine and doctors of dentistry. The doctors of medicine, of course, what I'm talking about as far as DSOs happened to medical doctors, my medical colleagues, 10 years or more ago, where the entire industry of physicians joined either large hospital corporations or large independent corporations of 50 to 100 physicians, either specialists, most of them a combination of generalists and specialists, for the common good, for their common good and the common good of the patient. So medicine now is under the care or direction of medical service organizations of one kind, whether the MSO, just use that description, be a hospital system or a trade name that includes multiple sites and multiple offices and multiple doctors, but all under a medical service organization. Well, that is medicine in 2022. And it's only going to get more condensed. I don't stay awake thinking about all the details of this, but it's obvious. It's happened. You see it. It is obnosis. Observe the obvious. And confront what you observe, and then act. Observe, decide, and act. Those are the three things you need to do. First, you need to observe it and observe what's really there, not what you want to be there. And then decide what you are going to do about it. And the right answer is not nothing. You can't do nothing. That's the wrong answer. And then act after you decide what you can do. So those are just facts that need to be confronted. And then I'll bring TMD into this in a moment, because TMD is one of those issues which I've covered extensively in our episodes here on TMD Demystified, that lends itself well to the doctor of dentistry understanding the entire mechanism of the oral and maxillofacial region, which the TMD is the linchpin, literally the linchpin of which the majority of facial growth rotates around, no pun intended. But joint does rotate, but the growth of the maxillofacial region is primarily driven by the growth of the temporomandibular joint. That is a physiologic, anatomic, embryologic fact. Remember, my PhD research was on facial growth and development. So TMD is a good example of a body of knowledge that needs to be emphasized to young doctors who want to learn about dentistry and become the doctors of the oral and maxillofacial region, of the oral structures. Whatever you call yourself, that's going to be, I guess, up for grabs. I like stomatologist, but there may be some other moniker that, comes up and you'd like to use. But as a doctor, and as we've seen in our medical colleagues, they are really more often than not now becoming managers of their specialty and the management system that they manage, because they have nurse practitioners, physician's assistants, technologists. They are more diagnosticians other than the surgeons. And we talk about the similarity between, a general surgeon or a neurosurgeon or a maxillofacial surgeon. That's a highly developed set of skills. And if you consider yourself a dental surgeon, cutting teeth, agreed. But we know that with enough practice and skill level, ability to use your hands well, and eye-hand coordination, it doesn't take a broad understanding of the basic sciences and how the body works, and all the things that go with that, to actually take a tooth and cut it down, or prep a crown, or prep a class 2 preparation. We already know that expanded function assistants are out all over the country, and now there is a substantial move afoot to have a secondary classification of dental providers. I'm not even sure what to call them. You can't call them dental assistants. Dental associate is the dentist you bring in your office, but a secondary level of dental provider who just cuts teeth. And that is the way it's going. Let's confront this. It's not going to go away. It's only going to get more in your face as time goes on. Additionally, Dr. Donoff has to say, an overemphasis on technical skills produces dentists who fill an intermediary role as that of technical experts of mechanical aspects of dentistry rather than healthcare leaders. And that's kind of what I'm bringing to your attention and solidifying and, backing up. And that is, if dentistry wants to take its rightful place as a healthcare provider, and I do emphasize that rightful, we have the right, we have all the technical knowledge, we have the basic science knowledge, and access to all this knowledge. We need to actually be managers of the profession, and the diagnosticians of the profession, and just look at it in a different point of view. How much better life would be for you, doctor, if you didn't spend your life bent over a patient, and you were able to direct the technician to do the class 2 prep or the crown prep with our magnification mechanisms, and with scanning. All these technical aspects become much simpler, and so a lower level of understanding can be educated to people who do this for you, and you align yourself with just the things that only you can do, and certainly that would include things like temporomandibular joints or pathology recognition, things like that, and have a higher level of technicians, not just hygienists in your office. Made the point. Regarding education, Dr. Donoff states in his editorial, dental education must align with medical and other healthcare professions education. Although interprofessional educational exposure is already an accreditation requirement, meaning, I don't know how they do that in the average dental school right now, that is interprofessional education between not only the specialists in dentistry, but between medical doctors. I don't think that goes on at all in any dental school. Dental education still falls short of its true collaborative potential. I guess that's a very brief and simple way of saying what I'm trying to get across here. The dentist needs to be much more collaborative, not only with other dentists, which the medical profession found out many, many, many years ago. They're much more collaborative than the dental profession, but the dental profession needs to be collaborative in a much deeper, much broader way with the medical profession, because, as I've said in a previous, and I think I entitled it, the dentist really is the medical doctor of his region. And you need to be thought of that. You need to use that. You need to practice that, which I won't spend much time on that, but same monthly JDA here has an additional article and I'm not going to talk deeply about the article, but it talks about, it's a narrative review on review of visceral throat and chest disorders causing non-odontogenic orofacial pain. In other words, visceral problems, heart, lung, stomach, stimulation of the central nervous system coming back as, and perceived by the patient as orofacial pain of some kind. It can be dental pain, it can be facial pain, it can be muscle pain, but generated out of the visceral organs, heart, stomach, lungs, and because of the anatomic nervous system and the vagus, there are well-known tracts that allow this to happen. Again, it is not that common, I agree. You don't want to spend your whole career as a dentist learning all about this, but it is something that, frankly, that's why the article is in this issue, is that very few dentists actually know even that exists, that you can have visceral damage, visceral pathology, which comes across to the patient as oral and maxillofacial pain. Although you all know about heart attack causing jaw pain, that's been promoted forever, but it's certainly not the only one. Another example of the dentist becoming much broader in his knowledge and scope and applying it and managing the patient dentally rather than doing all the technical features and procedures. Opinion, I think this is the way it's going to go. That's my opinion. How fast that happens, I don't know. I do know that with the onset of the consolidation of dentistry under management organizations, DSOs, dental service organizations, it's going to expedite these changes because the management organizations are going to take advantage of the options that that allow people to be more productive. Obviously, they're not going to tell by law the dentist what he can and cannot do. The doctor is the one who is licensed. But one way or another, the dental service organizations are going to avail themselves of methods to be more productive in those practices, whether it be through their hiring practices or supporting of political changes or supporting changes in the dental laws. You know, at some point it will become obvious to patients that certain procedures or practices or organizations are more productive and they do a better job and they avail themselves more of anesthetic possibilities, which is another total issue. I probably could make an entire episode just on the changes of anesthesia within dentistry, but it doesn't apply to, it's not going to apply to TMD, which is our topic here. And as far as temporomandibular joint problems and how that's handled, you know, it will become very obvious that things that are done in the past for the treatment of TMD that are not productive, that don't work, are going to be taken off the table. The number one that's going to be taken off the table is the night guard, which I continue to see constantly. I've talked about it, not trying to be overtly critical, but it is the fact. Observe what's obvious. Observe what is obvious. It's obvious that half the dental population still gives the patient a night guard and says, here's your TMD treatment. That's not going to work a whole lot longer because it doesn't work, and the dentists who do it are not productive in that, and there are better things that we now do work. So I think I made my point. The dentist needs to be the quality manager of dentistry. You know, he needs to be the doctor manager. He has the license. He is entitled to manage the quality. He is entitled to manage other people who are qualified to do it, who are licensed to do it. I think our licensing parameters are going to be changing here in the future. And I think fairly rapidly. Don't be afraid. Change is scary sometimes, but it isn't bad. Remember, you know, if we didn't adopt changes, we'd still be working in the dark ages or before. So food for thought. So the title that I chose, Paradigm Changes for Dentistry and TMD, there are paradigm changes on the horizon. A couple weeks ago, about 3 weeks ago, I attended for my own purposes, the grandest, largest dental service organization meeting in the United States of America, which is called the DICOMA meeting. It was held in Denver, Colorado, and has been for the past, I think, about 10 years. This year, it was amazing. It amazed me. It's the first time I ever went to that meeting to see what was going on in the dental service arena. There were 1,750 people there. It was a sellout. They couldn't hold any more people in the facilities. overspill into multiple hotels. And that industry actually has a big advantage. I'm not beating the drum for them. I am just observing the obvious. And if you talk to your colleagues, and I know all of you do talk to your colleagues and see what's going on out there, you see some of the aspects of what's going on, whether you think it's good, bad, or indifferent. There are huge changes on the horizon for dentistry, which is changing the paradigm of delivery, changing the technical paradigm. And my point here is based on the fact that the temporomandibular joint is one of those issues and one of those services that need to be well understood as this paradigm for dental delivery changes. I encourage you, the practitioners, to get involved with actually fixing patients who have temporomandibular joint symptoms. And it's pandemic. It's a pandemic problem. 45% of females have temporomandibular joint symptoms coming directly from the temporomandibular joint. And you can learn all about what I know about this on the other episodes. It makes you a much better doctor. It makes you a broader doctor understanding. Plus, you're able to treat these patients effectively, efficiently, quickly, and get the results that certainly a night guard or dry needling or Botox are not going to achieve. If you'd like to know more about what we do here at TMJ Services, you can pull up our website, www.tmjservices.net. If you'd like to talk to me personally, you can email me. We can have a chat on the phone if you'd like, Tony@tmjservices.net. If you'd like to talk to our Director of Marketing and Education, she can be reached at Naomi@tmjservices.net. And if any of you would like to join our expanding network of providers who provide our services and our device and protocol for the benefit of your practice, big benefit, financial benefit, and the benefit of your patients, big benefit, because it actually solves the TMD dilemma and conundrum. Give us a shout. For today, I am Tony Urbanek. I look forward to talking with you the next time, which should be, hopefully, God willing, in a week. I will do the next episode. This is TMD Demystified.